So guys, if you're just joining us, it's Dr. Mo here from Inspire Medics. We will get started shortly, so we'll get started in about 2-3 minutes. And today's topic is going to be on psychosis, schizophrenia, and PTSD. So we'll get started, as I said, officially in a few minutes' time. Whilst we're doing that, it'd be nice to hear where you guys are joining us from. So you can just let us know in the chat box where you are joining us from, so which part of the country, and also if you can let us know when you're doing your next exam, so if it's the RCA recording, for example, or the AKT exam, or the MSRA exam. And then finally, if you could also let us know when you're sitting the exam, but also which exam you're sitting at the same time. So a couple of housekeeping rules for everybody, just whilst everybody obviously joins us. There is a Q&A box at the bottom of Zoom. If you have any questions, you can type your answers into the Q&A section. There's the chat box if you want to make some general comments, if, for example, if you can't hear us or see us. And it's important that if you can't do that, just raise your hands. There's a raise hand feature within Zoom. And don't forget, as I said, if you're just joining us, if you can type into the chat box now where you're joining us from, which exam you're sitting, and when you're possibly going to be sitting that exam. So we've got a rough idea of which exams you guys are doing and when. And of course, don't forget, this teaching session is a 1-hour teaching session on psychosis, schizophrenia, and PTSD. So I'm going to hand over to Dr. Sandhu shortly, whilst we live stream to our Facebook groups, and then hopefully the comments will start coming through.
Yeah, perfect. Thank you very much, Dr. Mo. So obviously, guys, welcome to the Sunday evening iMedics revision webinar for those preparing for the MSRA, AKT, or the RCA exam. So let us know where you're joining. There are people still joining at the moment. Whereabouts in the UK are you? So in other words, which city, which VTS, and what exam are you preparing for? And I will give you a quick shout out before we wait for everybody else to join us. It is being streamed live to the iMedics, AKT, RCA, and MSRA revision group. So welcome if you're joining us on Facebook. If you do have any questions, you can just type them into the Facebook chat underneath the live video. And similarly, if you're obviously on Zoom, you guys know how it works on Zoom. So you just kind of type in the Q&A section, or you can use the chat feature. So we've got Mehreen Kiran from Sheffield. Welcome, Mehreen. We've got Fatima Lawal from Bolton doing the AKT exam in April. We've got Friday Esagwu from Grimsby, who's looking to do the AKT exam later this year. We've got Dolopo Olaleye from Reading, part of the Reading GP VTS, doing the AKT exam in April. Let us know where else some of you other guys are joining while Dr. Mo's getting the live stream up and running. So just let us know, we'll give you a shout out. You probably know that the website was down a little bit last week, but well, good news, the website is now up and running. Our tech team have been working on things in the background, so it is up and running. If you do encounter any problems, just let us know. We always say to all of our customers, if you get a problem, just let us take a screenshot and let us know which browser you're using, and then our tech team will look into it. But it is now up and running, so hopefully you are kind of utilizing our free AKT question bank. Few more people joining. Let me know if you need to give us a shout out. Mo, when you're ready, if you want to make a start, if you're streaming, and I'll just double check to see if we are live in the Facebook group. And then
guys, I'm just streaming this to Facebook in the next 2-3 minutes, and then we'll officially get started. So as you might recall, if you're just joining us, our teaching sessions tend to be relatively straightforward. We cover 3 key points for each learning topic area. We do obviously cover those are the high yield points which we expect to come up in the exam. And whether that's the MSRA, the AKT, or the RC exam, it's the type of knowledge the examiners would expect you to exhibit or have. And for that reason, it's the topic areas we cover within the subjects that we're going to teach on. So we should be going live to our Facebook group now in the next 60 seconds or so. If you've just joined us, welcome. If you can let us know where you're joining us from, and also which exam you're sitting as well. This is getting recorded for your reference, and it will be uploaded onto YouTube. But the benefit of the live session is that you can ask questions in a live session, and of course you can interact with us. So Dr. Sandhu's already done a couple of shout outs for names, which is super handy. And then right now I can see the Facebook stream going live. So as soon as it's live, we'll get started. So VCAS, if you want to double check that, it should be going live now.
Yeah, so I'm just, yeah, it's just gone, let's have a look. I think it's just, yep, it's now gone live, yeah, perfect. Excellent, yeah, so over to you then, Mo, if you want to make a start.
Yeah, absolutely, guys. So let's get started. I'm just waiting for my screen just to refresh for a second. And then I'll basically make the screen full size so everybody can see nice and clear. Okay, guys, let's get started. So we are going to cover the latest NICE guidelines. So we do cover, obviously, the most up-to-date knowledge that you need. It's important to know that the psychosis and schizophrenia topics, which I'm going to be covering, have been updated. And the reason for that is because the ICD-10 classifications and the ICD-10 criteria for diagnosis of schizophrenia has changed. So to give you an outline of what we're going to do, we're going to go through the latest guidelines for psychosis and schizophrenia first. Then there'll be an opportunity to ask questions. So if any of you guys want to ask any questions, we'll do a couple of promotions because I appreciate some of you may be looking to do mock exams, have some coaching for the exams that you are going to do, like the RCA exam. And then Dr. Sandhu will be covering PTSD, and also you'll get an opportunity to ask questions about PTSD. And then finally, we'll cover our social media channels, which some of you may already be following. So this is a quick show of hands if you can hear me and see me clearly, because if you can do that, I'll continue. So this is raise your hands in Zoom if I can see a quick show of hands. Okay, Delapo, fantastic. I can see your hands gone up. So you can lower your hands, guys. Let's get started. So as always, we cover three key learning points for each topic. And as I mentioned, it's going to be high yield learning points that you're expected to know for the exam, whether it's the MSRA, the RCA, or the AKT. But we always start off with a recap to begin with. So NICE actually amalgamates psychosis and schizophrenia into one topic area. And we'll start off with a recap first. So we'll start off with what psychosis is, according to the NICE definition. So psychosis is a significant alteration to perceptions, thoughts, moods, and behavior. And obviously, it's closely linked to schizophrenia. I'll explain how closely it's linked and why it's linked and in what way on the next slide. It's important to know that in terms of the breakdown of the classification of psychosis, it's broken down into positive symptoms and negative symptoms. So you may already be aware that schizophrenia has a similar classification. It has positive ranked symptoms and negative ranked symptoms, but we're going to give you a baseline first because a lot of this will make sense when I come on to the second slide. So what are positive symptoms? You know, you've studied this at medical school. This is a recap. And of course, you may have done it during some of your psychiatry rotations or A&E acute medicine rotations. So positive symptoms are essentially symptoms which occur for the patient, which seems to be additional things that they're experiencing. So positive symptoms you can think of as additional experiences or processes that are occurring, whereas negative symptoms, you tend to get things taken away from the patient. And I'll explain that in a bit more detail. For example, positive symptoms, you can get hallucinations, and those could be visual, auditory, for example, or sensory. You can get delusions. Those can be fixed delusions, or they could be false beliefs that the patients may have. For example, they may believe that they are the second coming of Christ, as an example. And then you have disorganized behavior, speech, and or thought. So the patient's perhaps not talking coherently, or they're jumbling up different words in a sentence which doesn't really make sense, or they're stringing sentences together which don't make any logical sense. It's all disorganized. And these are what we term positive symptoms because, in essence, there's an additional layer of a thought process going on within the patient. There's additive things going on in the patient's experience. With negative symptoms, the reverse applies. So what's happening with negative symptoms is just taking something away from the patient, or something's being taken away from the patient. So those can include emotional blunting, reduced speech, loss of motivation, self-neglect, and social withdrawal. And so if you want to memorize those two classifications, that's probably the way to remember it. One's taking away, and the other one's adding to the patient's experience or symptoms. Now, how does this tie into schizophrenia? So that's a good question. So schizophrenia is actually a psychotic disorder, and it's the most common psychotic disorder. Other psychotic disorders can be, for example, drug-induced psychotic disorders, bipolar psychotic disorder. And so the ICD-10 classifications, which have been updated and are now incorporated within NICE, the definition is different to psychosis. And if you've previously studied psychiatry many years ago, this classification has now changed. So previously what you needed was you needed 2 positive rank symptoms and 1 negative rank symptom, as an example, in order to make a diagnosis of schizophrenia. Now that's changed. Now the ICD-10 classification, which is what NICE uses, says that you only really need at least 1 positive rank symptom, which occurs most of the time for a month or more, and you're able to make a diagnosis of schizophrenia. And of course, that's going to be made by a psychiatrist. It will be relatively uncommon for a GP or a hospital trainee to be making a diagnosis like that. Although, of course, it may be your differential diagnosis or your working diagnosis. The formal diagnosis will come from a psychiatry specialist. So schizophrenia is, so there's 2 ways of diagnosing schizophrenia. So this is the first slide, and I'm going to come on to the second slide very soon. So if you have these positive rank symptoms, and at least one of these, and they've been going on for more than a month, for most of the time within that month, you can confidently make a diagnosis of schizophrenia. So that could be auditory hallucinations. And if you remember that, that's a positive rank symptom. It could be thought echo, thought insertion, withdrawal, and thought broadcasting. And again, going back, that ties in with positive rank symptoms. Then you can get delusions of control, influence, passivity, or referring to the patient's body or limb movements. And those can be specific thoughts, actions, or sensations that the patient may exhibit. And again, if you look back, again, it fits in with positive rank symptoms, which would be a type of delusion, which was the second bullet point. And then finally, there may be delusions of other kinds which don't relate to control or influence. So for example, control or influence delusions might be that the radio is controlling my thoughts, and that is a delusion of control or influence. So a delusion of influence. Another example will be if the patient believes that there's a microchip inside their head and they believe that it's controlling them, that will be delusion of control. And persistent delusions of other kinds, so culturally inappropriate delusions, which is what the third bullet point refers to, is if somebody thought, for example, that they were, as I referred to earlier, the second coming of Christ, or they thought they were God, that would be culturally inappropriate. And the reason for that is because whilst, for example, certain individuals in the world believe in religion, that's culturally acceptable. And so if it's not culturally acceptable or inappropriate, that would fall in within this classification of being one of the following attributes, which broadly speaking falls under positive rank symptoms. Now, the other way you can diagnose schizophrenia is if you have 2 or any 2 of the following, which are essentially negative rank symptoms. So it's interesting how the ICD-10 classification has changed. As I said previously, you had to have positive rank symptoms as a minimum in order to diagnose schizophrenia. But the ICD-10 classification now says either you can get 2 or more of negative rank symptoms, or you can get 1 or more of positive rank symptoms. And that's very important to be aware of, especially for exams. So in terms of negative rank symptoms, there is some slight variation here. So you can see that delusions, fixed or false beliefs, fall under positive symptoms, but persistent delusions of any form also form a category within the negative ranked symptoms that's being given in the ICD-10. And then the rest of them effectively are negative ranked symptoms. So breaks or interpolations in the train of thought resulting in incoherent or irrelevant speech, catatonic behavior such as excitement, posturing, waxy flexibility, negativism, mutism, and stupor, negative symptoms which are mentioned here. And then if there's an overall consistent change in the quality of the patient's behavior or their interest or how they seem to be interacting socially, again, that's another classification which falls under the second part of how you can diagnose patients. So you can see there's an overlap here in some of the positive and negative ranked symptoms, but it's important to know mostly in the second classification, most of these are negative ranked symptoms. And if we go back, emotional blunting, reduced speech, loss of motivation, self-neglect, social withdrawal, which you can see that the last 2 and 3 bullet points refer to, whereas the first 2 bullet points refer more to positive ranked symptoms, which will be delusions or disorganized behavior, speech, and or thoughts. And so it's important to be aware of these. It may be an exam question that comes up in the AKT or the MSRA. It's unlikely to be an RCA type question or scenario that you would be expected to record, because it's a bit outside the remit of what the RCG curriculum covers. So moving on to how you would manage schizophrenia. So of course, as GP trainees, you may see a patient who's psychotic, or perhaps it's a working diagnosis of new working diagnosis of schizophrenia. And NICE have broken it down quite nicely. So the role of a GP or a GP trainee or a specialist doctor in a accident emergency setting or hospital setting essentially is to triage the patient and then refer them onto the relevant services at the appropriate time interval. And as long as you understand that, you're generally going to be fine. So it's probably quite clear that if a patient presents with schizophrenia or psychotic type symptoms, and they're high risk of harming themselves or others, so they've expressed, for example, that they want to commit suicide, and they've got a time and a date planned for it and how they're going to do it, or they are they've planned hurting somebody else around them, a family member or a friend. This would fall under a high-risk category. And for those who are high-risk categories as patients, you want to refer them as a same-day referral for specialist assessment. So on that same day, they should be referred to the specialist, and they should have an assessment on the same day. And that will be a psychiatry specialist, of course. And the reason for that is they're probably going to need admission. They may need sectioning at the same time. And if you find actually that they're willing to go involuntarily, that's usually the way you want things to go. But if not, they're not willing to go involuntarily, to an A&E setting, to a place of safety, to the psychiatric wards to be assessed, then essentially you're going to have to section them under the Mental Health Act. So we have covered the Mental Health Act in a different webinar. We're not going to touch on it here, but this is just for your information so that you know how it ties into a presentation of high-risk schizophrenia or psychosis. Then you have those patients who are not high risk to themselves or to others. And in a scenario like that, the NICE guidelines say that you want to refer those patients to an early intervention psychosis service, but as an urgent referral. So not a same day, as an urgent. Now, NICE haven't made very clear what that means. So it could mean within 72 hours, it could mean within a week, it could mean within 2 weeks. If you're not able to get the patient into an early intervention psychosis service urgently, then NICE say it's okay to speak to crisis and get their advice, and obviously get them to make arrangements to see the patient. So essentially, you've got a bit more time to make the referrals and the assessment. If the patient who you suspect of having schizophrenia or currently is psychotic is not at high risk of hurting themselves or others. And then there's a third classification that NICE makes, is those patients who are in the prodromal phase of the illness. So in the prodromal phase of the illness, whether it's schizophrenia or psychosis, patients begin to withdraw, their behavior starts to alter, their mood may become depressed, they don't seem their usual self, they may become irritable, they may not be sleeping particularly well. And you may start to develop these symptoms, which may then lead on into schizophrenia or psychosis, or may even possibly be a relapse if they've already been diagnosed with previous psychosis or schizophrenia. And again, here, NICE is quite clear. You should refer to the early intervention psychosis service or to the psychiatric specialists. And that can be usually done as a routine referral, as opposed to an urgent or a same-day referral. The other key learning points are that you should not be starting antipsychotics in primary care. So at no point should you be starting risperidone, for example, or haloperidol in a primary care setting. That will be expected to be started by a psychiatrist in a secondary care setting, or a safe psychiatric unit where obviously things can be monitored and the patient is being observed regularly. And then once the diagnosis has been made, as well as the role of antipsychotics, other treatments which would usually be offered would include CBT, that could be individual CBT or family-based CBT, and then art therapies. These are the recommended guidelines by NICE. So we've covered 2 key learning points so far. One is how you make a diagnosis. Number 2 is how you manage a patient depending on their risk profile. And then the final key learning point is a lot of these patients that you'll see on a day-to-day basis won't be new diagnosis of schizophrenia or psychosis. They'll actually be patients who've already been diagnosed with schizophrenia or psychosis, and perhaps you're managing them for another condition. You may be managing them for diabetes, maybe they've come in for acute cellulitis problem or an acute medical problem, or they're passing through hospital, for example, for surgical issues. Maybe it's a fracture, they've fallen over somewhere. And in terms of holistic care, you need to be aware that these patients are higher risk than the general population for the following conditions. I'm going to explain to you why each one of those is relevant when you're consulting, for example, on the RCA exam, or if it's an exam question that you have for the MSRA or the AKT exam. So then there's an increased risk of suicide within this demographic of patients. And it's always important to ask these patients whether or not they've had any thoughts to hurt themselves. And if they say yes to that question, so we're talking about an RCA setting or hospital setting now, or a GP setting, you want to ask what kind of plans they may have in place. Have they decided about a time and a date? Have they told other people? These are the key screening questions to ask, which allow you to determine how high risk the patient is. Secondly, these patients are also at increased risk of cardiovascular disease and type 2 diabetes. This can be a side effect or as a result of the types of medications that the patients take. So patients who are on antipsychotics are automatically at increased risk of type 2 diabetes and hypertension, and increased risk of heart attacks and strokes. And of course, there's regular screening for these patients. These patients have regular, for example, HbA1cs, lipid profiles, but it's something that you need to be aware of because it could be an AKT exam that comes up. What would you monitor in this patient? It could be an RCA video that you submit for the Royal College exams. So you would ask the patient, oh, would it be okay to check your BMI and your blood pressure before you leave as part of your examination screening assessment that you do for the patient? And then the other things which is interesting to note from the latest NICE guidelines is that there's an increased risk of smoking-related illnesses. It seems that the patients who've been diagnosed with schizophrenia or psychosis are more likely to misuse substances, but also more likely to be smokers. And again, it's always important to ask these patients, do you smoke? Do you use any recreational drugs? And in a scenario like that, you would essentially, if they said yes in management for an RCA type setting or a hospital type setting, you would offer brief intervention for smoking. So you would say something like, Mr. Smith, we do know that smoking is not good for your health. It can increase the risk of heart attacks and strokes, as well as various different cancers. There is a stop smoking cessation service which is available in this hospital or GP surgery. And if you're interested in accessing it, you just need to book an appointment at the front desk if it's a GP setting, and the nurse will be happy to have a discussion. That's a brief intervention I've just given in about 10-15 seconds, and that's what a RCA examiner will be looking for. Well, that's what, for example, if you're doing a COT in a hospital setting or something for your portfolio in a hospital setting and a consultant's observing, that's what they would expect. And then finally, don't forget social exclusion. Because of the symptoms and the way psychosis and schizophrenia presents, these patients can become very lonely and socially isolated. So you want to ask about if there's other people around them. Have they got good social support? Have they got any friends and family that they can talk to? Because the more isolated they are, the more likely their condition or their general mental health is going to deteriorate. So we're just going to recap the 3 key learning points. So number 1 was we did a recap of what psychosis is, and obviously we broke it down into positive and negative ranked symptoms. Number 2, we covered the new ICD-10 classification. So this is interesting. The new ICD-10 classification is broken down into 2 parts. There's 2 different ways you can diagnose. Number 1 is if a patient essentially has positive ranked symptoms, which have been going on for a month or more for most of the time. or if they've had any two of the following, which includes negative rank symptoms, but also some positive rank symptoms as well. But they're mainly negative rank symptoms in the bullet points listed. And again, it's for more a month or more, which has occurred for most of the time within that month or that time period. The second key learning point is how you would manage these patients depending on their risk profile. If they're high risk, it's the same day specialist assessment. If they are not high risk, but you're worried, if they're not high risk, but it's, for example, new diagnosis of potential psychosis or a working diagnosis of schizophrenia, you want to get them involved with the early intervention psychosis service urgently. That usually means within a few days. And if you can't get through to them for that to be arranged, you want to get in touch with crisis, and the crisis team will then have a follow-up in place. So they'll be seen, for example, in the next 48 hours. And contact will be made by the crisis team. And then if a patient's going to prodromal symptoms or the prodromal phase where they're having early symptoms to suggest that they might go on to develop psychosis, schizophrenia, but they're not high risk, then you can routinely refer to the early intervention psychosis service or to the psychiatry outpatient service. And then the third key learning point was, don't forget, you need to watch out for certain things: increased risk of cardiovascular disease, increased risk of type 2 diabetes, increased risk of suicide, and of course, there's an increased risk of cancer and social issues, which include smoking and substance misuse. So what we're going to do, guys, is there's a couple of questions which are coming through. We're just going to bounce out for a second whilst we just talk you through a couple of promotions we've got on offer on our website at the moment. So just bear with us for a second. So quick show of hands, who here is going to be sitting the AKT exam this year? Quick show of hands if you're sitting the AKT exam this year. So this raise your hands as a raise hand feature in Zoom. If you just raise your hands, you're going to be able to. Okay, so 2 people are going to be sitting the AKT exam. Okay, so 4 people. I can see 4 people have raised their hands. Okay, guys, if you can just lower your hands for a moment. So if you just lower your hands for a second, if you raise your hand, slow them for a second. A quick show of hands: how many people are going to be sitting the RCA video recording assessment in the next 4 to 5 months? Quick show of hands if you're sitting the RCA exam in the next 4 to 5 months. So we've got 4. Again, we've got 4 people, 5 people who are sitting the RCA exam. Okay, fine. If you guys want to lower your hands, and then finally, if you're sitting the MSRA exam in the next 1 to 2 months, if you can just raise your hands. So that's the RCA exam. If you're sitting it in the next 1 to 2 months, if I can just get you to raise your hands. Okay, so 2 people. I think 2 hands went up there. 3 hands went up. Just keep your hands raised if you're sitting the MSRA exam in the next 2 to 3 months. Okay, fine, good. So we've got a relatively even split of people sitting these exams fairly soon. Okay, guys, so first things first, for those of you who are sitting the AKT exam, we highly recommend joining us for our AKT Big Mock. It's a 3-hour realistic exam, which includes health administration, statistics questions, and also clinical questions, which mirror the real exam. After the 3-hour 10-minute exam, you then have a 1-hour lunch break, and then we'd go through 6 hours worth of teaching, which covers the questions, the answers, and the most up-to-date guidelines. The next exam sitting we have is on the 18th of April, which is on a Sunday, and it's a full day. Very, very cost effective, $99.99. And we highly recommend those of you who are interested in having a practice mock before the real thing. This is something that you definitely need to do. Myself and Dr. Sandhu will be teaching in the afternoon. And of course, the exam questions are up to date with the latest guidelines, like things like cervical screening, HPV guidelines, the combined pill, statistics, mean mode median, for example, how to calculate funnel plots, and so on and so forth. It's a really good way of seeing whether or not you're ready for the real exam and what areas you may be weak in. And so Dr. Sandhu is going to put the link into the Zoom chat chat box for you. If you are interested, we've got a limited time sale price on this. It's normally priced at $129.99, and at the moment we are pricing it at $99.99, which is an amazing value for money. The other thing that if you're sitting the AKT exam that would like to make you aware of is our gold package. So our AKT gold package is basically a combination of different things. So 750 videos, they're mini lecture videos. You then have 750 NICE guideline podcasts. So these are all the up-to-date latest NICE guidelines that you can listen to in your car, on the way to work, on your lunch break. We have 3,750 MCQ questions. So you get a bonus 750 MCQs within the video. And we send out free learning flashcards. Now with the gold package, what's so interesting is that we've got a don't pass, don't pay incentive on offer, which means if you sit the AKT exam and you've subscribed to the gold package and you later go on to not passing the AKT, we'll refund you all your money minus a small admin fee. And so really it's a no-brainer. You get all those videos, you get all those podcasts, you get extra questions and free learning cards. And if you don't pass, you get your money back. So for those of you who really want to access a resource which is super intensive in the sense that there's lots of information, there's different ways of learning, video, audio, flashcards that you can keep in your wallet, MCQ question banks as well at the same time, that's the package to go for. And we've had lots of doctors now take that offer, the don't pass, don't pay, since it's been live over the last 1 to 2 weeks. For those of you who are sitting the RCA exam and are going to be submitting videos, we've got a full-day RCA Advanced Communication Skills course. We basically go through high-yield topics which are likely to be tested in the assessments that the examiners will mark you on, the criteria that the examiners will mark you on. So we cover 5 high-yield communication skills areas. These aren't your standard communication skills areas like good eye contact. Everybody knows about good eye contact and speaking clearly, and signposting. We're talking about advanced communication skills, how to, for example, navigate a consultation when there's multiple problems within that consultation, or an ethical scenario, or a patient who gets angry or frustrated, or a result station which the patients come in for. How do you score top marks in those scenarios? So we go through high yield cases, the advanced communication skills that you need, but we also do 5 live cases on the day. So you can role play with ourselves. We'll be patients, you can be the doctor, and you can experience for yourself what's needed to get the top marks, and we'll give you feedback on the day. So again, this is amazing value, $49.99, and the next one's on the 28th of March in a few weeks' time, between 10 to 5. And it's a full day teaching. So again, there's a limited time sale price. It's normally priced at $79.99. It's currently $49.99, which is like £30 off. And that's highly recommended, because the amount you will learn on that course is going to far outstrip the $49.99 you'll pay. You'll go back, look and think that's the best $49.99 I've ever spent. And then finally, for those of you sitting the MSRA exam, don't forget there's a gold package for that. Again, very similar in its setup, except you've got SJTs in the exam question bank. You've got 750 videos, 750 NICE guideline podcasts, the free flashcards. And again, it's don't pass, don't pay. So Dr. Sandhu is going to include the link for you guys there. What we're going to do is just bounce into the questions for a moment so that we can get some of these questions answered before Dr. Sandhu comes on for his teaching. So let's see here. Okay, so we've only got one question, guys. It's from Anonymous. How does a Schneider rank symptoms? Oh, sorry. Are the Schneider rank symptoms no longer relevant? So the short answer is yes, they kind of are. The Schneider rank symptoms were still classified as a positive and the negative. And within the definition of psychosis, that's still used. The positive rank symptoms and the negative rank symptoms were, broadly speaking, historically, were the Schneider rank symptoms. But what's happened now is that to diagnose schizophrenia, NICE and the ICD-10, so this NICE uses their diagnostic criteria from ICD-10. ICD-10 has changed. Before, you needed a combination of positive rank symptoms, and you definitely needed positive rank symptoms as well as negative rank symptoms. But now what's happened is you can actually make a diagnosis of schizophrenia purely on positive rank symptoms alone. But then also you can make this, according to the old definition, a combination of positive and negative rank symptoms, as long as there's a minimum of 2 of the following. And so that's the key thing to know. Firstly, you can make a diagnosis if there's one positive rank symptom, which has been bullet pointed here, or if there's at least two of the following, which include all the negative rank symptoms and two positive rank symptoms. You can again make a diagnosis of schizophrenia if it's been going on for more than a month for most of the time within that month. And that's the key thing to remember. So yes, do go back to your Schneider rank symptoms. You'll see a large overlap. But it's still relevant, except probably the terminology has changed. NICE don't no longer use Schneider rank symptoms anymore. They use positive rank symptoms and negative rank symptoms. And that's the terminology that should now be used going forward if you're speaking to your consultant or your colleagues in general practice. So guys, what I'm going to do is going to hand over to Dr. Sandhu, and he will now cover PTSD. And of course, the guidelines have recently been updated for that topic as well.
Yeah, perfect. So thank you very much, Dr. Mo. So I will do my screen share. Let's get over to that side. There we are. So guys, welcome to the second part of your iMedics revision webinar. The second topic, sticking with the theme of psychiatry, is post-traumatic stress disorder. This is based on the current NICE guidance. So we'll keep you up to date so that you are up to date whether you're preparing for the MSRA, the RCA, or the AKT exam. So similar theme to how we normally do it when I'm obviously on, as you guys already know. It normally involves me giving you a definition of what the condition is, key features, risk factors, and of course going through the management of the condition as well. So what is the actual official diagnosis? Well, of course, when you're talking about psychiatry, it's the ICD-10 definitions that we look for, and post-traumatic stress disorder is normally a feature that occurs after a major stressful event in your life. The stressful event or situation. So what ICD-10 rather defines it as, which NICE uses in their guidance, is a kind of stressful event or situation that is perceived as threatening or catastrophic in nature, which is likely to cause distress in almost anyone. So anyone who sees it, it doesn't matter who you are, you're likely to perceive some kind of stress from witnessing that event. How does it happen? Well, and obviously we know that post-traumatic stress disorder, we talk about, people often talk about armies, and wars and so forth, but actually it can affect anybody. And there's lots of different things that we see day to day, which can lead to post-traumatic stress disorder. So for example, if you've had a serious or a life-threatening car accident, or you've witnessed a car accident, you were not yourself injured, but you were driving past but you saw it happen in front of your eyes and somebody died or somebody broke a leg or something like that. Physical or sexual assault, and that will include, domestic abuse, whether you've witnessed it or you've been a victim of that. Work-related problems, like, related to trauma that people have seen at work. Also other things, so it might be, a husband, for example, who's witnessed the birth of his child, but there's been something serious that's happened and he saw it happen, and that thought then goes through his head time and time again, or that it affects the mother in a very, very negative way. Of course, as we talked before, wars and conflict and torture are all things that can leave you kind of at risk of getting post-traumatic stress disorder. In terms of the actual diagnosis, so remember, we go back to the ICD-10 diagnosis, which NICE uses when we go to diagnose somebody with post-traumatic stress disorder. Normally, it will be someone who's directly been involved with or experienced that traumatic event. But the second criteria is it could also be someone who's witnessed it. So it might not have happened to you, but you just happened to be there and you witnessed something which was quite horrific, and it's led you to having post-traumatic stress disorder. Sometimes people have what they call learning of a traumatic event, which occur, learning about something which happened to someone who's close to you. So for example, when you read the news, you hear about people who have been killed locally, for example, in your local news or in the national news. And then if that someone is someone that you know, or if it was a family member, and the police talk you through what happened, and they say the person may have been shot or stabbed or something, and they describe it, that can lead to post-traumatic stress disorder, because the loved one who may not have been involved in the actual event and may not have even witnessed it, but when they're being given a description by, for example, the police force, that leads them to have obviously nasty memories going through their head. Repeated or having kind of repeated exposure to that kind of trauma is another thing which is part of the diagnosis, and that might be, for example, someone who is like a first aid responder who has come up to the scene of a car accident, and they've seen someone who's dead, whose bone, is broken, and it's coming outside the body. Something really extreme, which, would affect any of us, and that will affect somebody. It might be a paramedic or a police officer or just a normal individual who's walking through and they've come across something which is obviously very, very kind of difficult for them to witness. To actually be diagnosed with post-traumatic stress disorder, you have to have the symptoms listed below for at least 1 month. Now, 1 month seems to be quite a common pattern with a lot of mental health disease. They normally talk about having the symptoms for at least a month, and post-traumatic stress disorder is very similar. The most important thing really is this first box here. So it's basically someone who reports re-experiencing of the event, which can happen in the daytime when they're awake. For example, they may have kind of lots of flashbacks, so they can see themselves back in that nasty moment that they witnessed, or they're having lots of thoughts about it, or indeed they can have nightmares. So when they go to sleep at night, they keep on having flashbacks to that disastrous event that they witnessed or that they heard about. And these are the kind of typical symptoms of someone with PTSD. And then there's other things. So the second box, we talk about kind of avoiding anything that reminds them of the event. So people were like, okay, that road is where that happened. I'm not going to drive down that road. That park is where that incident happened. So they just avoid that park completely, because if they walk into that park, it triggers off memories of that really horrible event. Hyper-arousal. So that's someone who becomes extremely alert. So a minimal stimulus makes them really hyperactive and hypervigilant. And they become not paranoid, but they become a bit more kind of aware of who's around them, who's walking there. Was that a tree that I heard, or was that somebody in the bushes? Those kind of things start to go through their thoughts. It has a negative impact. So box number 4, on their mood and their thinking. Box number 5, there's emotional numbing. So that's kind of like where they start to lose that feeling of being happy for other people or even themselves. Disassociation. So you start to kind of move away from people around you, from your emotions. Emotional dysregulation, interpersonal difficulties in their relationships, and negative self-perception. So these things kind of come together. So you have someone whose emotions are all over the place. They kind of find that they just find it hard to be happy, and that's affecting them in their day-to-day life because they can't then maintain relationships. And obviously then, that leads to a negative feeling that feels like you're worthless. What are the risk factors? So who tends to suffer with PTSD? So we know that it's common in members of the armed forces, but we also know that it's common in emergency workers. So whether that's an ambulance paramedic or a police officer or a prison custody officer, firemen and women rather, ambulances, A&E doctors, GPs, anyone who witnesses anything which is kind of, what normal people might describe as gruesome. Nurses as well. Journalists are other ones to be mindful of. They may be, reporting on a war zone, and they see things which, lead them to go on to develop post-traumatic stress disorder. Refugees and asylum seekers, so people who have been in conflict zones, have suffered a lot of abuse. They've seen a lot of things, and certainly from my time working as a GP, both in Greece and for the Rohingya refugees in Bangladesh, this is common because they go through so much trauma that post-traumatic stress disorder is a serious issue in this population, and that's why there's a huge push to get lots of mental health services into conflict zones and refugee camps that occur all over the world. Severity of the incident. So again, the more severe the event that you witness, the more likely you are to have obviously some degree of post-traumatic stress disorder. Sometimes there is some evidence to suggest that women in general may have higher rates of post-traumatic stress disorder, but it will depend on the age and what kind of trauma you've experienced. Younger age people as well, so people who are quite young and they're exposed to stuff which is quite extreme, puts them more at risk of PTSD. Previously having experienced trauma, having lots of other stresses in your life, and coming from a lower socioeconomic background with lack of support to guide you through and help you through is another risk factor. And of course, last but not least, having a history of other mental health problems like depression, anxiety, OCD, psychosis that Dr. Mo talked about earlier on. All of those things can leave you more prone to developing post-traumatic stress disorder, which of course is known as PTSD for short. So how do we manage it? Well, subclinical post-traumatic stress disorder is someone who's got symptoms that are relatively mild, and they're normally there for less than a month. And so the NICE guidance says you can actually just actively monitor these patients, signpost them to support networks, which we'll talk about in one of the slides that's coming up. And of course, you know, we arrange a regular follow-up now. Both myself and Dr. Mo are GPs, so we do have an advantage here in the sense that we can say to the patient, you know, Mr. Smith or Mrs. Smith, we will call you back, you know, in a week's time or in 2 weeks' time to see how you're getting on, and you can kind of keep that follow-up quite close if they're struggling. And obviously, if they're starting to get better, you can perhaps follow them up in 4 to 6 weeks. And you know, so you've got that kind of flexibility, if you like, but it's a case of just monitoring, and often, you know, they can come through that and not go on to get severe post-traumatic stress disorder. Then there's the second type. This is what the NICE defines as the clinically important post-traumatic stress disorder. These are patients whose symptoms do go on for a month. They become quite severe, and they do start to interfere with their day-to-day life. And so NICE says you should be getting them into specialist mental health services, which are specialized in trauma-based psychological therapy and or drug treatment, you know, with medications. What kind of treatments do we have? So psychological therapies that we should know of. There is a specific type of cognitive behavioral therapy, which is focusing specifically on trauma. And that's, you can have up to 12 sessions, but sometimes more. And it focuses on 2 things. There's exposure therapy and trauma-focused cognitive therapy. So in exposure therapy, basically the patient will be, you know, with a counselor or a therapist, and they will basically be confronting the traumatic memory, usually by kind of going through what happened. And then they're repeatedly exposed to the situations that they've been avoiding. And then the therapist teaches them to kind of overcome that fear. And the more you're exposed to it, the more you can come through that barrier that's stopping you from functioning. And then you can obviously overcome that fear and no longer avoid that situation. And trauma-focused cognitive therapy, which is also the other aspect of it, will kind of look to identify patterns in your brain and thought process which occurred after the trauma because of the trauma. And then they can basically teach you how to kind of alter your thinking so that you don't see that traumatic event as a threat like you did or like you have been doing, you know, in recent weeks. Then there's the other thing to be mindful of, and that's eye movement desensitization and reprocessing, which is often for short known as EMDR. And again, normally about 12 sessions are given, and these are for the more complex cases who need more longer term treatment. They can give it to children as well from the age of 7. And it basically uses stimulation of both eyes, and it's basically eye movements which and tapping and tones that are kind of predicted while the person is going through memories of that traumatic event. And they believe that what that does is it kind of re-alters the brain kind of pathways that are going on through those flashbacks, and to try and interfere with that pathway and try to make sense of that experience, and then hopefully reduce the likelihood of that becoming something which you know, frightens that patient in the future. So they try to kind of break that pattern, and then you can obviously then hopefully go on to live a life with, you know, not being affected by what they've witnessed. There's obviously medication as well. The classic ones that are given for post-traumatic stress disorder are antidepressants. NICE specifically mentions venlafaxine, which is interesting, but you can give SSRIs, for example, sertraline or citalopram, depending on what you feel comfortable with. I mean, I'm comfortable with all 3. maybe if you're a GP trainee, you may be more familiar with sertraline or citalopram, but NICE doesn't specifically give a specific one that we should go for. It does specifically mention venlafaxine or an SSRI, so you do have a choice there. Remember, when you're counselling the patients, if you're doing the RCA exam with all antidepressants, keep it nice and simple. So Mr. Smith, it will work on a hormone in the brain called serotonin, which has fallen down in your case, and that's why you're getting these symptoms. And so what we're trying to do is trying to build up that hormone in your brain, but it will take about 2 to 3 weeks before that happens. So you may not notice anything, or you may feel worse before you feel better. Does that make sense so far? And of course, your follow-up should always be that we'll call you back in 2 to 3 weeks, see how you're getting on. You do need the treatment for 6 months, and you shouldn't stop it suddenly, because remember, you can get nasty mental health flare-ups like serotonin syndrome if you stop these medications abruptly once you've started them. The other thing, very relevant to RCA, for those who've got the exam coming up. Now, when you sit the exam, some people often naturally say support group, but you'll look even better if you can actually name specific support groups, which is why I've included these 2 slides. This is from the current NICE guidance. There are specific support groups for patients with PTSD. For example, there's a military charity called Combat Stress, which is specific for ex-army men and women who've got severe PTSD. There's the Rape Crisis in England and Wales, which again is a charity that provides a specialised service for women and girls who've been raped or have experienced sexual violence. Victim support is a free, confidential support for people who've been a victim of any sort of crime. There's CRUISE, which is a UK charity that will provide support for people who've experienced a recent death in their family, whether that's a traumatic bereavement or just someone who's passed away, and obviously the patients found it very difficult to cope. There's Veterans UK, which will again provide support for military people who've come out with mental health issues. Anxiety UK gives information, usually through fact sheets, and it's got PTSD in there as well. And there's the National Child Traumatic Stress Network, which is actually an American website that gives fact sheets, videos, and information for children who've experienced a traumatic event. And these are, of course, from the current NICE guidance. That will leave us open to any questions. While those questions come up, if you are on social media, don't forget to follow us. We did post the links in earlier. If you're on Instagram, do follow us at I_medics. The Facebook revision page for AKT, RCA, and MSRA was posted as well. You can watch these webinars on there. There's revision cards, YouTube revision videos, and lots of good content. Go onto the YouTube channel as well, Inspire Medics. Do like, subscribe, and follow, where you'll see again lots of good revision videos on there. Twitter, iMedics, or at Inspire_Medics, and you'll find us there. And again, you've got lots of good revision on there that you can use for your revision. And that takes us on nicely to some questions which have popped up. So I think there's nothing specific. So
very quickly, we're waiting for those questions to come through for only for the next 20 minutes, because we appreciate you guys coming live onto the website, onto the webinar for the teaching. You guys are probably the most proactive out of all the GPs that we've had, the doctors that we've had. We've had some issues sending out emails. Normally we have at least 200-300 people register for the webinars, and a lot more turn up on the day. But because we do appreciate you coming to the live session, taking time out to obviously learn and prepare for the exam, we're going to do a one-time discount code only for the next 15 minutes. And it's a 25% discount code. So those 4 products that we talked about, you'll get 25% off. That 25% discount. So the discount code is 2521. I've just written it down. I'll just show you how you can access that, because we're only going to run it for the next, we're only going to run it for the next 15 minutes. So let me show you. So let's say you were thinking about booking the AKT mock. For now, if I add it to cart, and you could do this for the RCA Advanced Communication Skills course, you could do this for the gold packages for the AKT or the MSRA, but you'll get 25% off the price just for the next 15 minutes for you guys. So if I type in the coupon code 252021, and then if I apply the coupon code, it will basically reduce that price by 25%. So it should be about $74.99, that price. And there you can see, yeah, the price has dropped to $74.99. So only for 15 minutes, this is for you guys. We're not going to unlock this code for anybody else, or the recordings that go out. It's only for the live attendees. You get 25% off of any products, which is a lot more than the discount code of the 5% that we sometimes have on offer on our website. 25% off for those who live attended the webinars, for those 4 products: RCA Advanced Communication Skills, the Gold Package for the AKT, the MSRA Gold Package, and of course the AKT Big Mock. So I'm just going to hand over to Dr. Sandhu, and just remember that that is only 15 minutes until it locks out, and then it'll disappear.
Perfect. So as I said before, really, there's no specific questions that have propped up, which is good, apart from, like I said, there was a compliment there from SH, which I think is short for someone's name. Thank you both. The talk was very helpful. It's worth adding in the Google reviews link. If you did find this useful, guys, we do normally ask if you guys don't mind writing a very short review on Google reviews. 125 plus doctors have done so. We've got 125 plus reviews at the moment, and we're grateful for that. It's a 5-star review as well, so we do appreciate that. Most of our things are free. I'm sure you've been on the website. You'll see that we've got a forum now, which you can use. We've got the blogs as well, which has got lots of revision material that you'll find useful. A quick question has plopped up from Delapo in subclinical post-traumatic stress disorder. So the question, I think, is, I'm just going to try and make sense of that. So in subclinical post-traumatic stress disorder, if a patient presents less than a month after the traumatic event, is that what it is? Well, essentially, what it basically is someone who's got mild symptoms. So it's not really affecting their day-to-day life as much. They have experienced something. It might be a car accident, and you're right, it might just be within the last 2 or 3 weeks. And they might be okay. They might not be hypervigilant. Their emotions may not be, like we described the term. We describe the term emotional numbing, yes, they may not have got to that stage, which is why you can do the watchful waiting. And then obviously, you know, if they then go on to get the severe symptoms, we can then go on to the route of the psychological therapies, plus or minus the medication. Perfect. So that was the question there. So if there's any other questions, guys, do let us know for the next 30 seconds. So Dr. Mo's posted the Google reviews thing. So do remember just to leave us a review if you can today, guys. That'd be pretty useful. The website is back and running. Do make use of the discount codes for the AKT mock, for the RCA Advanced Communication Skills course. And if there's any topics, as we normally say to everybody, just let us know, drop us a quick message. And we can get some more topics. Obviously, we'll be back anyway within a couple of weeks with the next 2 topics. But if there's anything specific you want, just let us know. Anything you want to add, Dr. Mo, before we wrap up for today?
I think, guys, we're still trying to, our website went down for 5 days last week. We're still trying to get some of the bits up and running. The question banks are all there. The forum section, some of the data got wiped. So just bear with us if there's some small glitches on the website. That the contact us form, the live chat. Support agents will be there. You can just drop them a message. Do use our resources. We've got free resources, and we've got the AKT Big Mock and the RCA Advanced Communication Skills course and the gold packages as well. Those have got a lot of information, and you can learn in different ways, of course, depending on the type of learner you are. Do join us for the next webinar. So the next webinar will be in about 2 to 3 weeks' time. We've got lots of exciting projects, and then Dr. Sandhu is very briefly going to show you our blog site to our website. We've got some super articles which have been launched. Breaking bad news, and also there was another super topic. So Dr. Sandhu is just going to do a screen share for everybody to show you those super blog articles. And what we've done is condensed all the type of data for a specific topic into one nice blog article, so you can read about it, understand the background, the different models of breaking bad news, for example. So Vikas, do you want to do that? Shall I do it from my side here?
Yeah, I don't mind. So let's have a look. Let's have you got it? Oh, here it is. Yeah, I've got it. There you go.
Safety netting and breaking bad news. Yeah, we can see it.
Yeah. So basically, guys, so what you do is you go up to the blogs bit here, and you go to the doctor's blogs, which is there. You have got patient information leaflets, which are very good for those preparing for the RCA exam, and also good for you guys. They're quite short and succinct. But here's an example. So, you know, we've got lots of different articles that you might find useful, latest guidance in asthma and so forth. But as an example, if we take acute asthma in children, you'll see a very nice and easy to follow severity, different types of the normal values for moderate or severe or life-threatening asthma. Management is very useful for different phases, easy to digest, nice and colourful, bullet pointed, and a summary at the end. So it's good revision. It's free to use, and like I said, it's very, very useful whether you're doing the MSRA, the AKT, or indeed even preparing for the RCA, and just your good generic revision. And there's lots of different articles like this on there, so use it to your advantage. Like I said, this will, if you're doing the RCA, be quite useful. And we've got lots of different blog articles that are going up regularly, and again, they've been made nice and easy to follow. So it's like a note format, if you like. You can use it on your phone, your iPads, as well as your laptops. But nice, quite useful phrases there as well, which you'll find quite helpful. This is very relevant for those doing the RCA exam. And again, it's a very useful resource. It's free and it's made for you guys. So just use it to your advantage, and it's just all available on the iMedX website.
Last thing to add, guys, that discount code will lock out in 10 minutes. So if you are interested in booking into the MOCs, the RCA exam, a communication skills course, or the gold packages for the MSRA or the AKT, use it in the next 10 minutes, because that's just for you guys whilst you are live with us. We'll hopefully see you in a couple of... okay, we've got a question come through. What's the best course for the RCA? So, Dr. Tufel, we would say our our RCA Advanced Communication Skills course is very, very focused. It highlights the key advanced communication skills that the examiners see in the top scoring candidates. We condense down essentially a week's worth of information into about 5 hours, and we role play within the day as well, so that we can give you specific feedback in terms of what your strengths are, what you need to change, and what kind of score you would get on the actual day if you submitted that video to the Royal College. So there are other courses out there, of course. We also do one-to-one coaching if you're struggling, Dr. Tufel. So if you're finding that you need more specific, specialized, one-to-one personalized feedback, we do that as well. But definitely, we've had lots of good feedback for our PLAB 2 Advanced Communication Skills course. I think I've still got the link here. We do.
But basically, I mean, the key thing is if you go onto the reviews that we were telling you guys about, you can actually scroll through and you'll see the reviews that other doctors, GP trainees, and various other doctors and students at different stages of their careers have given us. So if ever in doubt, just check out the reviews and you'll see that they're consistently relevant and really, really good reviews that we've had. So Nicola Pennell, someone who joined our last RCA, was it the AKT? Yeah, it was the RCA course, that's the one. So, we always say that while the people are in the course, the GP trainees, we get them to review us there and then, and they're all really good. They give us some good feedback. So, look for the feedback. Feedback's pretty good. It's pretty consistent. And the scores were high. So my CSA score was 95 out of 117. And Dr. Mo was taught by the RCGP prize winner from, was it 2017 or 2018? So we've got lots of experience between us. So, but utilize the reviews to have a look, and then hopefully that will help you make your decision.
Okay, guys, we will send out a recording of this webinar in the coming 2-3 days. Do join us for the next webinar. The email should be back up and running from our side. So a lot of people didn't get emails, or they went to the spam folder on this occasion, but things should be back to normal. And of course, take care, stay safe. I think most of you may have had the COVID vaccination. The lockdown slowly starting to ease off, and it'd be nice to start seeing people face-to-face once more in clinics, and of course, face-to-face in general life as well. So from myself, Dr. Mo at Inspire Medics, thank you for joining us, and take care. And I'm sure it's the same from Dr. Sandhu as well.